I hope I'm coming out loud and clear. Good morning, everyone. My name is Richie Jara-Lazaro, so the J is pronounced like an H. Um, the, the, this is an honor, and I thank the SKBC for inviting Roche Diagnostics Medical and Scientific Affairs team to give you a presentation on the value of diagnostics. And it's such a privilege because working in a diagnostics company, we are able to significantly contribute to the pandemic in providing our services to the laboratories and pathologists and doctors all over the world. Why I'm speaking this on behalf of the team is because, well, I'm a pathologist. I joined Roche 1 year ago. And prior to that, I was working in a CRO and also in Singapore General Hospital as a practicing pathologist. But now with the COVID pandemic going on, I have many healthcare worker friends and colleagues in the front line. And so this has become a passion for me to continue on the COVID education to doctors and now to the SKBC team. And yes, I will also thank Johnny-Tse, Frederick Weber, and Roche Diagnostics Korea for this opportunity. So I'll share a bit about the background of COVID-19 and some diagnostic tests and technology in COVID-19 management and COVID-19 initiatives of Roche Diagnostics. So this is an updated slide from the WHO just turned in an hour ago. And you can see here the global profile of the pandemic. So there are about almost 3 million confirmed cases to date all over the world, with 73,000 new cases today. And in Korea, who has successfully flattened the curve with a global example of the way to go massive testing, has 10,000 plus confirmed cases with a small number of 244 deaths, and these numbers have not been significantly changing every day. Now, one thing I want to highlight in this slide is that these numbers of confirmed cases and the new cases are all data derived from laboratories. So this, in fact, is a true value of diagnostics within a pandemic. So in any pandemic, any strategy or any data that is put out in the news are all lab-driven data. And that, to me, is a significant value of diagnostics in a pandemic. So policies on lockdown, social distancing, which is more physical distancing actually, the socioeconomic disruptions that have resulted and the consequence of increased unemployment and so on and so forth have impacted the whole world in a very negative way, creating a climate of fear and distress, which has not been of this level for many, many years. So it's an unprecedented type of pandemic. And on a personal level, of course, it impacts families who are required to stay in their homes. And for me personally, I show you here a picture of my cardiologist uncle, who was the first healthcare worker to die of COVID in the Philippines. So he was a prominent cardiologist. And what happened was in January, his patient consulted him for a different reason, and the patient didn't even know he had COVID. So that was the time when Philippines had not yet locked down its borders. And so he was the first to get infected and one of the first doctors to succumb to the disease. And the sad story is that even his junior colleague cardiologist has also passed on because of COVID. So his name is Dr. Raul Jara. So he's a cousin of my father. So the world today has this goal to fight the disease and the virus, to contain its spread, to combat coronavirus, and to really save lives, whether directly to patients or indirectly to all of us impacted in some negative way. And the only way to do this is really to really showcase and squeeze out every value of diagnostics that are available in every country. So let's discuss a review of what we already know. So coronaviruses are a large family of viruses that cause illness ranging from the common cold to more severe diseases like the Middle Eastern Respiratory Syndrome and the severe acute respiratory syndrome. So SARS-CoV-2 is a new strain of coronaviruses, which originally was named novel coronavirus 2019 when it came out of Wuhan, when there was an outbreak of pneumonia-like illnesses in China. And it was in February that it was renamed by the WHO to SARS-CoV-2. Now, COVID-19 is the coronavirus disease that is caused by this strain, as also named by the WHO. So let's talk a little bit about the virus and its structure, because there's still quite a lot of insights that can be derived from looking at the viral structure alone. So the word corona is actually derived from a Latin word which means crown. And there will be virologists who describe the virus structure as akin to the appearance of the solar corona, which is the outer atmosphere of the sun, well seen during a total eclipse. So as you can see, the crown-like structure is because of the spikes around this spherical or circular structure. So this SARS-CoV-2 virus is a protein molecule with a single-stranded genetic material called your ribonucleic acid, or RNA. And this single-stranded RNA is enveloped in a fatty layer, which is actually very thin and fragile, according to virologists. On its outer surface, you have these spikes, and these proteins have very specific functions, especially your spike protein or your S protein, which is what is responsible for attaching to the host cell of the human body. And the host cell is located in the respiratory tract and in the lungs of an infected person. And you have your envelope or E protein, your nucleocapsid or N protein, and the membrane M glycoprotein. So if in so much of my readings, there have been virologists who describe the structure to actually be very fragile and easily destructible, and the best weapon for that will actually just be simply soap and detergent. So we've been asked to wash our hands for 20 seconds. And it's not so much because, of course, it will wash the virus away, but actually it's the foam caused by the soap and the detergent which destroys the envelope of the virus and kills it in a way, just by simply washing our hands. Also, this viral envelope is sensitive to heat, so it can also be destroyed through ultraviolet rays. Alcohol is another disinfectant that we can use, provided that the alcohol is more than 70% in concentration, which can again destroy the viral envelope. Now, alcohol that we know, like scotch, gin, vodka, even the best out there, unfortunately cannot be used because that's only up to 40–45% alcohol. That would have been a cool thing to have it as a disinfectant though. And being fragile, even hand sanitizers are also advocated for its use. So mark these proteins, the S, E, M, and N, because these are also the proteins which are going to be detectable through antibody testing. Now let's review the famous coronaviruses that we know. So there was a SARS outbreak that also started in China in 2002 and infected about 8,000 people, with severity of cases patients needing mechanical ventilation amounting to about 35%. And the case fatality rate of that SARS outbreak was about 9.6%. Now, case fatality rate is the number of deaths out of the total infected people. So this is a CFR, which is a rough gauge as to the severity of the outbreak. Now, the MERS coronavirus, which started in Saudi Arabia in 2012, and the next biggest outbreak next to that country is South Korea in 2015, infected a smaller number of people, but having more severe cases out of that small proportion, amounting to 50 to 89% of cases. So in South Korea, it infected 186 people, and out of them, about 20 to 30 people died. And the case fatality rate is about a high 34%. So fortunately, the MERS outbreak did not last very long. Now, currently, we have the SARS-CoV-2, and it has been likened as having the most similarities with SARS-CoV of 2002 in terms of its viral structure and in terms of its symptoms, but then it also has some differences to all of these coronaviruses. So again, it started in 31st of December 2019 in Wuhan, China, and became a global pandemic as declared in March by the WHO. So currently, as you saw in the first slide, it has infected millions of people, and the percentage of severe cases is around 20%, which appears smaller than the other coronaviruses. But if you notice, the numbers are way so much higher because of its highly aggressive transmissibility. It's just way more contagious than all the other viruses. So the death rate to date is about 202,000 people, which gives us a CFR of 6.8%, which is kind of high because if you really think about it, the 2.9 million infected people that are being shown in our data is actually an underreported number. Given that there are so many asymptomatic carriers, there are labs or countries which have delayed testing or have limited testing capabilities, and of course the delayed resulting will keep these numbers a little bit lower than what it should be. So it is expected that with massive testing, if it is at all feasible and implementable in countries, this 6.8% can actually be way lower to hopefully the 3% that Korea currently has. So what else do we know about the disease? We know about the spread through respiratory droplets. So every time an infected person sneezes or coughs, there's a release of the respiratory droplets that can be propelled up to 6 feet distance, and hence the social distancing policy of at least 6 feet or 2 meters away from one another. We know it can be contaminated through direct contact, and that's why we can no longer shake hands, transferring from hand to hand the virus. And if we touch our face, specifically our eyes, nose, and mouth, we can also get the virus into our airways. And indirect contact is when we touch contaminated surfaces, because as we know, the virus and the respiratory droplets can stay on surfaces for several hours, up to even 3 days in plastic, and surfaces like stainless steel for a good number of hours. So the danger is getting the virus into our airways, our mouth, our nose, and even the mucous membrane of our eyes. And what happens is that upon entry of the virus into our airways, the virus, through the spike protein molecule that you saw on the initial slides, has this very strong binding affinity to the ACE2 receptors, or the angiotensin converting enzyme 2 receptors, that are located in the lung linings, the lung blood vessels, and in the airway tract of the human host. And once it's inside these ACE2 receptor cells, the viral RNA is released into the cell, and the virus uses the machinery of the human cell to replicate itself and make multiple copies of itself. And once there's a release of numerous numbers of new virants into the bloodstream, this elicits the consequent inflammatory processes in the human body, causing the most common symptoms of a non-specific flu. So these would be fever, a dry cough, fatigue, shortness of breath, muscle pain, sore throat, and you can add to the list some abdominal pain, diarrhea, and for some less symptomatic infected people, they even complain of loss of sense of smell or loss of taste, which is actually in and of itself not specific to coronavirus either. It can be caused by any viral illness for that matter. So the disease takes about weeks. From the time the person is infected, there is an incubation period, which is about up to 14 days with an average of 5 days. Hence, the isolation period of the 14 days policy for most of the quarantine period for travelers, for example, because only after 14 days, roughly, can symptoms start to begin, causing the disease, the COVID-19 syndrome. And there is a latent period, which is what we call the pre-symptomatic stage, where the infected person can also transmit the virus to another person. And this part, actually, how contagious the person is not very clear. How if asymptomatic carriers, for example, can transmit the virus to another one or two people. That is still not very clear. But we do know that once the patient has the disease, that patient this is like the peak of its communicability, and the virus can be detectable on average until 20 days. But having said that, I've had friends who've stayed in the hospitals for at least 48 days, even recovering from ICU, for example. And once the patient is discharged from the hospital, whether or not the virus is still communicable is again uncertain. So there's still a lot we don't know as well. So there's no specific medicine because this is a new strain of virus, and we are struggling so much to prevent its transmission and to treat it right now. Every drug out there is still under clinical trials. So lung pulmonology guidelines will divide the disease course into a mild or a severe or a critical phase. So if the patient is having mild symptoms only, the patient can actually treat himself at home in an isolated manner with support treatment. And vitamin C with zinc and vitamin D would be very helpful in boosting the immune system of the individual. Of course, good nutrition, good amounts of sleep to trigger a robust immune response, and even mood management, because it can be very lonely in isolation. And once the disease has progressed to severity or a critical stage, that's when antiviral therapy is given. And the most famous drug that we know is the hydrochloroquine, which is actually a malarial drug, which they say may help, or the others say they may not help either. And it's combined with azithromycin, which is an antibiotic. And depending on the symptoms of a severely ill COVID patient, then there could be anticoagulants or blood thinners, steroids, drugs that modulate the immune system, and antibiotics, because it's very common that bacteria get superimposed into the viral infection. And of course, oxygen therapy, because the most compromised would be the lungs. and eventually respiratory support. So let's look at the COVID-19 patient journey, beginning with its incubation period, where the patient is infected but without symptoms, up to the time the patient has symptoms, and upon consultation, the doctor needs to differentiate COVID from another flu or another bacterial infection, to not overtreat or not even overreact, and to diagnose it and confirm it, and probably leading to hospitalization or a home quarantine. And within the hospital, it is very important to monitor the clinical course to identify patients at high risk to progress to severity or a critical condition. And of course, treatment and monitoring the effective treatment is important until the patient's recovery and or possibly lead to demise. And it is in these phases, all just summarizing at least 4 points in the patient journey, where diagnostics are very critical in identifying infected patients, distinguishing from other diseases, monitoring the severity and knowing how to treat them, and leading to decision-making whether or not the patient can be discharged or potentially admitted to the ICU. So let's talk about diagnostic tests and technology. So this is the WHO definition of in vitro diagnostics, or what we hear as IVD. So IVD tests are a subset of medical devices, and these tests are used for in vitro examination of specimens derived from the human body to provide information for screening, diagnosis, or treatment monitoring purposes. So an IVD test may include the reagents that go with it, either in a kit format or separately, as well as the calibrators and controls. And in vitro testing may be performed on a variety of instruments, ranging from a small instrument, a handheld test, or more complex, robust laboratory instruments, which you can see in the subsequent slides. So IVDs are actually in everyday medical practice, accounting for about 2% of worldwide healthcare spending. And IVD tests influence more than 60% of every clinical decision-making of patients, regardless of disease. So how do diagnostic tests address the medical needs in COVID-19? So the first will really be to identify the infected patients. And the challenge here is in those who are what we call the silent spreaders, and identifying them in a cluster or out of a group can be very tricky. And the high volume of the rising number of cases every single day is also a huge challenge for a laboratory or for a country. So the test needs to be very sensitive, accurate, and fast. And the recommendation by the WHO and CDC is what we call the nucleic acid amplification test, or the NAAT for diagnosis, which in simple terms is a PCR-based test, or a real-time RT-PCR test, which is real-time reverse transcriptase polymerase chain reaction test. So that's a mouthful, but RT-PCR is becoming familiar because it's always talked about in the news today. So taking now like 2 strands of the viral genome, comparing the SARS of 2002 coronavirus and the SARS-CoV-2 virus, and you can see that they have fairly similar genetic sequences, and the orange bands that you see correspond to the targeted polyprotein, which is the ORF1AB. So it's open reading format 1AB, which is a polyprotein existing in the SARS coronavirus. And then, as you recall, the E gene and the N gene encode for those proteins that you see on the spikes of the coronavirus surface. Now, the trick to identify on a PCR test would to see at least 2 out of these 3 targets to be confirmatory of SARS-CoV-2. So what happens is the patient who is suspected of COVID-2 or SARS-CoV-2 undergoes a nasopharyngeal swab, which is where this long piece of swab is entered into the nose or the nasal cavity, up to the narrow part of the nasal cavity, way back to the throat. So my friends who have experienced this have described this as very uncomfortable, as if the swab is scraping the bottom of their brain, and it leaves them with a headache afterward. And another way to also swab, which is kind of less sensitive than the nasopharyngeal approach, would be through the throat or the oropharyngeal swabbing. So for most screening tests, they actually do both. And this photo is a swab booth in South Korea, which is actually an exemplary example of a very good way to protect a healthcare worker who is performing the swab on patients, at the same time protecting the healthcare worker from contracting disease. So many countries have actually replicated this nasal swab, this swab booth example from South Korea. And upon submission to the lab, the laboratory needs to extract the RNA strand. So the RNA strand, through using some solutions and chemicals, the RNA is isolated and then subjected to the PCR test, and the ribonucleic acid strand within the PCR instrument will have to be converted into a DNA strand. So how do you convert RNA to DNA? It's through an enzyme. This is called the reverse transcriptase enzyme. Because in a normal cell, actually it's from DNA to RNA. So if you reverse that, it's RNA to DNA. So it's a reverse transcription process. And the PCR, what it does is the strands, which is comprised by the complementary DNA-RNA hybrid formation, make several copies of these DNA strands and in a process called DNA amplification, until such time that the amplification reaches an amplification threshold that will allow the PCR instrument to identify the presence or the absence of the coronavirus in the specimen. That's simple cellular biology as best as I could. So now RT-PCR is currently the gold standard for coronavirus testing today. And the key factors to look for in any diagnostics test will be the sensitivity and the specificity, where it should be very high for both, with sensitivity capturing true positive cases in patients who really have the disease, and specificity ruling out those who do not have the disease. So these parameters need to be above 90%, and RT-PCR is currently the most sensitive technique to date. And this is an example of an RT-PCR result that has been produced by one of our Roche RT-PCR instruments. So you have a pool of samples, and out of these samples with target 1 and target 2 corresponding to those genes that it had identified would be positive, and this patient, or there are 2 patients in this list who have positive coronavirus or COVID-19. Okay, now there are several types of diagnostic instruments catering to the laboratories depending on the volume that is feasible to be processed in any particular lab. So in small volume scenarios, the same process of RNA extraction happens, but this is usually a manual process performed by a medical technologist, and it takes about an hour to do this RNA isolation process before it can be subjected into a PCR detection using, again, like this LC480 and the Z480 analyzer, for example, which are meant for relatively low volume lab scenarios. And all of this whole process produces about maybe 4 to 10 samples in roughly 3 hours upon reporting. So this is for small volume labs. Now for high volume settings, which is what we would recommend given the magnitude of the pandemic, where there will be a lot more samples that can be entered into high volume or high throughput instruments, such as the Roche Cobas 6800, for example, which can produce 384 tests in 8 hours, and Cobas 8800, which can test 960 samples in 8 hours. So given your 3-hour time frame, so in small volume labs, you'd probably have a dozen, but here you can have 96 results in 3 hours. So this making a very robust methodology where even the RNA extraction is all done in an automated manner along with the PCR detection. So this is technically a walk-away machine. And my virology friends are loving this instrument. So how do diagnostic tests distinguish other diseases from COVID-19? So as you know, the symptoms resemble any flu. So you need to rule out flu A, flu B, or some other virus. And given the blood picture where the WBC or the white blood cells also drop in COVID-19, and sometimes even the platelets also drop in COVID-19, there could be a misdiagnosis of dengue, and even dengue serological tests give overlapping results with COVID-19 patients. So this brings to mind the importance of ruling out other causes. So it's the same procedure of a nasopharyngeal swab, for example, where the swab is subjected to the same PCR technology to rule out, let's say, a streptococcal infection or influenza A or B or respiratory syncytial virus, for example. At the same time, blood can be drawn from the patient to test for procalcitonin, which is a protein that gives a positive result to indicate a bacterial infection. So these are just examples of how tests can be used to rule out other causes of fever, cough, fatigue, and shortness of breath, and not necessarily COVID-19 as a cause. And more important to every COVID patient is the progression to severity and how to treat them. And again, this is where diagnostic tests become very critical. So majority of COVID patients will have mild symptoms in about 80%, and the severely ill will be 15%, and those who are critically ill will be about 5%. So what is the difference between severe and critical? They're quite synonymous, and thankfully it's about only 20% of all patients who get infected with COVID-19. So severe is when there is dyspnea or difficulty of breathing or low oxygen saturation in the arterial blood. And severe is also when the lung infiltrates, causes you this opaque finding on X-ray, where the lungs, instead of appearing black, is showing you this opacities corresponding to diffuse pneumonia. And if it's more than 50% of the lung findings within 1 to 2 days, then the patient is progressing to severity. And critical is when the patient needs mechanical ventilation or going to a generalized infection like septic shock or other organ failure, which requires ICU admission. So the virus will cause all these severities and critical conditions if it is already leading to an acute respiratory distress syndrome, which is the leading cause of mortality of COVID-19. Now, not to forget, the virus may also attack the heart, and according to webinars, the ACE2 receptor that I described is not only found in the lungs. Some receptors may also be found in the heart, and that may be one reason why the heart is not exempted in being affected by COVID-19. And you have cases of myocarditis or even myocardial infarction, atrial fibrillation, for example, as part of the heart symptoms that can afflict any COVID-19 patient, particularly those who are elderly, like of a certain age, with comorbidities of hypertension as well. And the virus may also cause immunosuppression. So you might have heard of cytokine storm syndromes. So cytokines are inflammatory mediators. So when the virus infects the body, the body automatically elicits an immune response to fight it. But if it becomes so hyperreactive, the excessive or uncontrolled levels of the inflammatory mediator or the cytokines are released, and these activate more immune cells to attack the virus, and not only the virus, even all our other organs. So it results in a hyperinflammatory condition, which can seriously harm or even kill the patient. So how do you detect ARDS, the cytokine storm, or any form of organ damage in a patient afflicted with COVID-19? So some diagnostic tests, for example, would be measuring blood oxygen and carbon dioxide, getting the pH, the arterial oxygen concentration, or O2 saturation, using technologies like your blood gas sensors, which is shown in the photo. Now, cytokine storm, if it's impending in any patient, there is a need to monitor the level of inflammation markers, namely an interleukin-6, which is it's a specific cytokine that is elevated when the patient goes into cytokine storm. And I've mentioned procalcitonin, which is elevated when a bacterial infection gets superimposed on COVID-19. And these are blood markers where the blood is subjected to photometric and colorimetric technology using the COBAS instruments of Roche, for example. And now, to rule out any organ damage, we need to measure cardiac and renal markers, among other things. You might be familiar with troponin T and NT-proBNP, which are actually heart markers, which are used to determine heart injury caused by myocardial infarction or the simple heart attack, because it detects muscle injury of the heart. Now, D-dimer is a coagulation test which can give you high levels if the blood is becoming thicker. And when the blood becomes more thicker, there's more proneness to form blood clots. And that is why some severe COVID patients also suffer strokes or thrombosis or pulmonary embolism, for example. And kidney function tests, you can't run away with it. This gets really abnormal in any septic condition or generalized infection or when organs shut down. So these are just examples of some of the diagnostics used to monitor the clinical course of a COVID patient who is admitted in a hospital and monitored for severity. And what else has Roche tried to help out with? So there is a drug called Actemra, which is currently now in a COVID-19 trial. So Actemra is an interleukin-6 inhibitor. So it it inhibits that cytokine IL-6 mentioned in the previous slide. So this has already been approved in China for treatment of patients infected with the coronavirus SARS-CoV-2 who have developed serious lung damage and also have elevated levels of that IL-6 in the blood. And currently, I think it's on its phase 3 clinical trial. Now, how do we know if the patients can already be discharged from the hospital or if they need further isolation? Again, diagnostic tests will give you the results through RT-PCR, which is done twice according to the guidelines as per country guidelines, and generally all over the world. Will they require 2 negative RT-PCR results in at least 2 consecutive swabs from the nasopharynx and the throat collected more than 24 hours apart. So this evidence of viral RNA clearance from the upper respiratory tract together with clinical resolution of symptoms. So the patient no longer has fever, no longer has respiratory symptoms. The X-ray is clear with no evidence of pneumonia. So a symptom-free COVID patient with 2 sets of negative RT-PCR results can already be free to be discharged from the hospital and continue maybe for another 2 weeks of isolation just in case that person remains contagious to other people. So now we hear a lot about antibody testing. So how do serum antibody tests prove infection? Now, one thing to highlight is that the RT-PCR method measures the viral RNA presence, or it can quantify or detect it, whether it's present or absent. And it can do that as during the very early infectious stage up to for the time of recovery. Now, serum antibody tests do not detect the virus itself. What it detects is the amount of immune response or the antibodies produced by the human body to fight against the coronavirus. So we have 2 specific antibodies. We have the IgM or immunoglobulin M antibody and the IgG or immunoglobulin G antibody. And the serum IgM antibody actually starts to mount and become detectable 2 weeks roughly from the time of infection. So this makes it a very dangerous screening or diagnostic tool to diagnose coronavirus, because there is a risk of potentially missing out the presence of infection in the incubation period or in the pre-symptomatic or even the early symptomatic phase of the COVID-19 disease. And IgG antibody happens even after IgM antibody, so it can increase its levels sometime 2 weeks after the onset of symptoms. So this delay in appearance in the human blood makes it a risky screening tool for COVID infection. However, serum antibodies may be used to complement RT-PCR to monitor the clinical course, whether the patient is starting to mount an immune response, or to detect maybe an asymptomatic carrier and somehow mounted an immune response while staying at home. And so this in a way can still be useful as a complementary test to the gold standard of RT-PCR in RNA viral detection. So what we know that is out there, there are hundreds of these antibody tests, which looks like your pregnancy stick. So this was a headline that I've taken out of the Time magazine. So there's a finger prick method where you have this coronavirus kit, which even the blood from a finger can be dropped, and you can see if you can appreciate if the line appears in a few minutes for IgM or IgG, that can more or less indicate the presence of an ongoing infection for IgM or a recent infection that has been recovered in a recovered patient if it's an IgG. So this is not very robust in a sense because of the risk of some of these kits being unregulated and some of them having false claims to a high sensitivity and specificity. So each lab needs to validate the claims of the sensitivity and specificity. And most of the time, sometimes those parameters drop to like 33% sensitivity. So that is not a reliable test at all. So this May, Roche is coming up with their own antibody test, and that will be a laboratory method for blood taken or drawn out of a patient and subjected to testing in a laboratory using the Alexis immunology technology as shown in the instrument. So it would be most likely a more reliable result because this would be an approved testing with a whole lot of validations performed to prove its validity. So you've seen the value of diagnostics at the patient level and how it enables the management of the disease from the beginning of diagnostic confirmation, ruling out other causes of fever, cough, and shortness of breath, monitoring the prognosis of an infected patient, and monitoring the treatment up to discharge. And as you can see, the RT-PCR test begins in the diagnostic phase at the beginning and ends with 2 attempts of RT-PCR RNA testing. So it's a very uncomfortable journey for any patient with a whole lot of blood drawn in between to monitor his results in the blood, whether or not he's progressing to severity. And just imagine the discomfort. Along with the blood draws will be the intubation that happens in their mouth when they're connected to a ventilator. So it's a very, very rough time for a COVID patient. Now let's look at the value of diagnostics at the national level. And you can see some have called it a national test because testing is integral in empowering any nation's strategy in containment measures. So testing programs definitely include the swab testing, and this example of NHS having swab testing as one of its pillars for those who are with a medical need or where possible the most critical key essential workers like your healthcare workers and the frontliners as those who should be tested regularly for the presence of infection. And here in Singapore, in the news, they have called testing as a critical enabler of the fight against COVID-19 for 3 strategies: diagnose for early treatment, active case finding to ring-fence the clusters of infection, and surveillance of those who are in high-risk groups. And you have all heard about flattening the curve, which is basically the epidemiological curve to prevent it from spiking and become an overburden to the healthcare system, so quarantine measures have been in place to slow down the presence of infection and so that it can still be at least manageable according to the availabilities in the healthcare systems of a certain country. And what is actually being monitored as a goal of the pandemic in terms of epidemiology, again, using the value of diagnostics, is currently one infected patient can infect about 2 more people. So it has a 1:2 ratio. And this reproduction number or the transmissibility or the spreadability is called R0, or this R0 called R0. So the R naught being 1:2 today, the goal is to make it at least 1:1 or less than 1:1. So that is the goal of those managing the pandemics at the national and global level. So just the last part of my presentation is this initiatives from Roche Diagnostics. We have global and regional and country level initiatives where at the global level, so you've seen new COVID-19 tests. These have been increased in their production. We have clinical trials on the Actimra. At the regional level, we have a task force team to support countries for test setup. Training are provided, and COVID-19 educational initiatives have been ongoing as we speak. And countries have assisted labs in their workflow design, testing, setup, and technical support for the labs needing this service. So Roche has also collaborated with Medicus AI to come up with a digital triage tool, which is an app to manage the corona patient pathway. So it manages the untested population to help empower public authorities in collecting and analyzing anonymized data during a pandemic. And you have key contact people here who are helping out in the region with this initiative. So for our MSA team, in Medical Scientific Affairs team, we have come up with a series of COVID-19 webinars targeting the doctors and healthcare workers. So this is just an example of the live webinar that we had last April 17 for cardiology doctors. And this is the upcoming webinar that we will have in May, and this will be talking about blood gas. So in case any of you will be interested to attend. And lastly, this global health crisis has inspired unique partnerships because it's a global call to solidarity with the NIH having public and private partnerships with various pharmaceutical companies. So really now is the time to really come together and advance the development of new solutions to end the pandemic. Thank you. This ends my presentation.
Thank you so much, Dr. Richie. It was a very comprehensive and very interesting presentation. Thank you again. That was very clear. We understand
it took longer than I expected. I think I'm just a bit more chatty.
No, that's great. We are perfectly on time. We received a few questions. You can ask questions now via the chat. We received a few questions from, first of all, from Mr. Samuel Lee from Yulchon. It's a law firm here in Seoul. He's asking, isn't PCR also amplify all DNA, not only the COVID-19, RNA, and DSP within the sample and provide a lot of false negatives?
So, okay, so am I understanding the question correctly that the PCR detects the DNA of the virus? Actually, the virus has RNA. It needs to be converted to DNA because the DNA is allowed to amplify itself, and that's the one that's detected by RT-PCR. Yes, there can be false positives. There can also be false, false positives is for less of a risk. It's the false negative that is more risky. Depending on the RT-PCR sensitivity and specificity, which can range from 60%, 70%, depending on the instrument and the technology. Apart from that sensitivity, sampling is also a condition that needs to be taken into consideration because how the swabbing was performed, how it was submitted to the lab, how the lab processed the swab and extracted the RNA, all of these contribute as factors for potential false negativity. And that's the reason why in a COVID suspect patient, it's good to repeat the RT-PCR if it's a strong suspicion of the disease, and also to complement it with antibody testing, for example. And that's what they've done in some cases in Singapore. I hope
Thank you
it
very much.
answers the question. Yeah.
Yes, Samuel, I hope you're happy with the answer. You can always put a comment. Another question from someone else. Samuel asked another question. I will pass now with another question from Mr. Frank Stekau from Seoul. So in general, getting infected with COVID-19 is not depend on the age, rather your health is a key point.
Rather age versus what is the second part?
Age rather your health. Probably health condition.
Or other, no, can happen to children, can happen to elderly, can happen to pregnant women, can happen to babies. But the thing is, it's exposure. It's virus exposure where the respiratory droplets that's infected with the virus gets into another person's airway, regardless of that patient's age or medical condition. The problem is once it's in the person's body, how the body responds to the virus will vary person per person. So in an elderly, or maybe let's say a cancer patient, for example, who has lower immunity, will have a harder time fighting the disease. And that's the reason why a lot of the elderly people, a lot of people suffering from obesity, suffer from severe or critically ill conditions of COVID-19.
Great, thank you very much. A question now from Erwan Villefeu, President of Zulik Pharma Korea. Chloroquine is mannered to target parasites for malaria. Why will it impact COVID?
Yeah, there was a French study on a small number of patients. If I'm not mistaken, there's only like 14 or 20 plus patients, very small study, that experimented on hydrochloroquine as an antivirus. But yes, it's an anti-malarial drug. And because of the positive results that that French study had, it prompted the world to experiment on it, or even to try it as an off-label drug, meaning it's not indicated for COVID, but because of that French study showing positive results, they want to try it on their patients. And I think clinical trials are ongoing for that as of now. I cannot remember the mechanism of action, though, on how the drug works with the virus. That part, if I'm not no, I remember now. It alters the pH, the acidity, which is where when the virus attacks the host cell, it needs a certain acidity in the human body to enable its entry into the cell. So it's hypothesized that hydrochloroquine prevents the host entry of that virus. And it also prevents the replication of that virus in the host cell. That's the hypothesis for hydrochloroquine, which makes it supposed to work in COVID-19. But having said that, there are studies that say that it also doesn't work. so there's nothing conclusive when it comes to hydrochloroquine, to be very honest.
Yeah, thank you very much for your answer. Two more questions. Again, Samuel Lee. Is the serum antibody test specifically identify the antibody for COVID-19?
Yes.
Or does it also test for any antibodies for the body produce against the antigens, other antigens?
The serum antibody tests that claim to be serologic antibody tests for COVID-19 or SARS-CoV-2 have supposedly experimented on the virus, the immune response against the virus. For Roche antibody testing, for example, this has been the case. So, and as mentioned, the antibody attacks the S spike protein in that virus structure. So that spike protein is the antigen, and the antibody attacking that antigen is what is being measured by the antibody test. So it is it is specific to SARS-CoV-2. And there are other antibody tests also for flu, or like the influenza A, influenza B, which is another test because it's another target antigen that the antibody test measures. I hope that's understandable.
Yes, thank you very much.
Let's answer the question.
There is no more. I think so. I think there is no more question. I have two questions from myself. Basically, who owns the medical diagnosis? When a medical diagnosis is made, it's owned by who?
Okay, so once the diagnosis is made, of course, it's produced by the lab, right? But according to my microbiology colleagues, given the pandemic, these results are submitted to the Department or Ministry of Health, depending, of course, on country protocols and health ministry protocols. So there's a lot of documentation and submission to government authorities in terms of the data. So, of course, the diagnostic testing relating to the patient will be submitted as per typical to the clinician so that the clinician can treat the patient. So that's how it goes. The usual way of treatment and management happens in the hospital setting, but because of the pandemic scenario we are in, labs are obliged to also submit numbers, data, confirmed cases to the health authorities.
Great, thank you very much. It leads me to my second question. You are using, of course, big data mining, I guess, and how effective big data mining has been in your industry, and particularly during this crisis?
Oh, wow. You're asking me a question beyond my knowledge, my visibility. So big data mining, I kind of have an idea what you're asking, but I don't think I'm the right person to give you a very good answer. If there's someone in the audience from Roche who knows more about it, I would rather maybe defer that question to someone in the data mining department.
Okay, all right. Thank you very much anyway. Thank you very much again for your presentation today. If you have anyone have a last question, maybe. No, I think it's fine. Thank you so much again for being here.
You can submit to Frederick. You can submit questions to Frederick, and Frederick will submit to Roche.
Yeah, we can maybe do another session on data mining next time with Roche.
Oh, cool! Yeah.
Dr. Richie, it was really a pleasure to have you today, and thank you again for your great presentation. And all the best in Singapore, and wish you good health. Our next session, thank you again for joining us today. Our next session will be quite soon, next week, on the 7th. We are going to welcome Mr. Peter Prem, Head of Group of Strategy at Tetra Pak Switzerland, and he will speak about digital supply chain transformation. Thank you again for today for joining us, and wishing you a wonderful day. Take care. Bye-bye. Goodbye.